As you know, we're going to talk about GLP-1 agonist. What the heck are those? And natural polyphenols. I bet you guys have heard a lot more about GLP-1s rather than natural polyphenols for weight loss. They both play a role. They are both God-given tools, and I use them both in my practice. So off we go. Most of you know me, but for those that do not, my name is Cherise Branch. I've been a nurse practitioner. Lord have mercy. It's 25 years this year, since 1999. My background's internal medicine. I'm double board certified as a family nurse practitioner, as well as in geriatrics. I've had my own clinical functional medicine practice since 2016. Why am I qualified to give this class? Is it because of all those fancy letters after my name? It's because I've been there. I was a perimenopausal lady. I'm now a menopausal lady. Yay. I have a history of disordered eating in my teens and my 20s, enough to where all that caloric restriction back in the day does require me to be on thyroid replacement now. I also went through numerous courses of in vitro fertilization to have my 11-year-old. So I hit perimenopause in my 40s with a bang. So I have navigated a crushing period of fatigue and weight gain and hair loss and not feeling like myself and not sleeping well. And I feel very blessed that I can use my professional expertise and my personal expertise as well. So I think it's my personal expertise because I do have empathy for you guys out there struggling. I did not really fully grasp the ebbs and flows of my hormones, how they affected my mood, my ability to sleep, my ability to keep weight off, my ability for me to be there for my family until I fell into functional medicine 2015 through 2016. I did achieve my fellowship through the American Academy of Metabolic Medicine and Anti-Aging in Metabolic Medicine. I'm really proud of that. I completed that in 2018. So I do have a functional medicine practice. Because of the way healthcare is today, do I have folks that come in that think they're there to see me about their thyroid or their sex hormones and their blood pressure is 140/96 and we need to address that? Sure, I do. My roots are in internal medicine, and functional medicine is a beautiful extra toolbox that I get to use every day. So takeaways on semaglutide. Now, for the purpose, and you can tell I've been doing this for a while because I thought, you know what, I'm just going to cut to the chase. When I say semaglutide is a GLP-1 agonist. You can substitute for the word semaglutide Ozempic or Wegovy. Those are both GLP-1 agonist injections, or you can substitute the name Rybelsus. That is an oral by mouth semaglutide preparation we use for weight loss. Or you've heard of the new kids on the block, not that new, but a little newer than semaglutide, tirzepatide. Tirzepatide is Mounjaro. That's an injectable, and Zepbound. And those are used for diabetes and weight loss as well. So just know when I'm talking about semaglutide, I'm kind of talking about a grouping of medications. But before I put you guys all to sleep, if there's anything I want you to take home from this, because I had one gentleman text me today that he had been prescribed a semaglutide prescription and he was on the fence about taking it or not. I'm going to tell you, this is a great class of medication. Natural polyphenols are a great supplement tool that we have. But what I want to tell you about these meds, you need to run a different direction. And you need to know that you are wasting your money if somebody is writing you a semaglutide prescription. And these are some of the bullet points that I was just kind of pitching around when I was making these slides. It's kind of like, remember, you might be a redneck well, that's my take on this. You may be wasting your money if you show up and you're given an injection once a month at a clinic, you pay $300 and that's what you get. See you next month for your next shot. You may be a redneck if that provider has no awareness of other alternative supplements and other tools. You may also be wasting your money if nobody is optimizing your thyroid or looking at your sex hormones through a saliva, cortisol, and sex hormone assessment. Nobody's looking at you nutritionally. What's your B12, D3, and iron? We have to be healthy to lose weight. We do not lose weight to be healthy. If no one is talking to you about what the heck the word macros mean, proteins, carbs, fats, nobody's talking to you about movement. No one is talking to you about, it's really more important for you to look at the timing of when you eat. That beats out the calories that you're eating. And it's also more important is what is constituting those calories. If no one is addressing the gut-brain connection, there's very much compelling research now on our microbiome, the health of our gut, and strains of particular probiotics. You'll hear the term Akkermansia, and how they are involved in weight loss and weight maintenance. So please, you might be a redneck, you may be wasting money. If you may be wasting money, let me admit all these folks, you may be wasting your money if these other bullet points are not occurring. So please, 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 if there's any takeaway from this talk, this is it. So quickly, what are webinar expectations? You don't need me to read this out to you. Causes of weight gain, consequences, how do these drugs work? What are the side effects of these drugs? What helps us with long-term success? And are there some alternatives that we can use? Body mass index. Definitely don't want to spend much time on this. It's not very useful. It's your height and your weight. This application is very limited. It is not accurate for certain ethnicities, say African Americans. They have a higher muscle density than Caucasians or Asians do. They're going to weigh more, and muscle is going to skew someone's BMI and make them think that they are overweight or obese, when in reality, they have a lot of lean muscle mass. I personally had a lot of personal joy when I purchased an Omron body composition scale for about $80. I step on it in the bathroom. It gives me the amount of my visceral fat, the fat around my organs, my percentage of muscle mass, lean muscle mass, and my body fat percentage. That is ever so much valuable than the number on the scale. You can also do DEXA scans. You can do MRIs, and that's another talk than today. Just don't fall into the BMI trick. Thank goodness we here in the United States, we are similar to other westernized, industrialized countries. In other words, we stink. Look at North America, Canada, Australia. You know what? They stink as well. We are fat and we are overweight at alarming proportions. These numbers, the 69 and 36%, those are actually from back in 2016. This number of obese and overweight folks in the United States of America is a little over 70%, and 40% of us adults now are obese. And look at our children. What have we done to our kiddos? Think about this. Our age right now, we struggle with our weight. We did not look like the kiddos back when we were young. We were string beans, and we're still struggling with weight now. Can you imagine the troubles that they're going to have in 20 years? So what causes weight gain? Genetics. Yes, we can blame our mom and dad. And socioeconomic status. We all know you can buy 8 hot dogs at Wiener Schnitzel for $7.99, and a lovely salad at Jason's Deli is going to cost you a lot more. There are also such things called food deserts, where poor folks, economically disadvantaged folks, they don't have access to food. They have a Dollar General. They don't have a car. Obviously, they are struggling paycheck to paycheck. They don't have time to implement exercise. They don't have a safe place to walk in their neighborhood. For those of us who are very privileged and have champagne problems, we have sedentary jobs. We don't get up. We don't move enough. We tend to drive more and snack more. So there are plenty of causes for weight gain, and you're not here tonight to dig that deep into them. Depression. What is our relationship with our food? I'm Czech, half Czech, Bohemian, German. We celebrate with food and alcohol. We grieve. We have a keg of beer at funerals, right? So food and drink is present at every occasion and with every emotion. Then there's hormonal issues that cause weight gain. It is no secret that we, men and women, began losing muscle mass, hold on to your seats, at about the age 35. You guys thought I was going to say 55, right? It's 35. Definitely in our 40s, girls, but this is guys too, unless we are actively trying to maintain our muscle mass, build muscle mass, maybe put some creatine in our water jug when we go to DTAR Health Center. We are actively engaged in strength training. We are going to be losing muscle mass, and muscle makes us more insulin sensitive. Being more insulin sensitive helps us with our weight. Here's a big one we don't think of very frequently: drug side effects. How many of you ladies were on birth control for 10 or 15 years? Ladies gain weight when they are on birth control for the most part. Antidepressants can cause weight gain. Allergy medicines like Allegra, Claritin, Zyrtec, over-the-counter meds, those alter our gut microbiome, our gut's garden. When we do not have that garden mix correct, Too many bacteria or too many bad bacteria in our garden, too many weeds, it makes it an uphill climb for us to lose weight or to even maintain our weight. So do know drug side effects impact us negatively in regards to our weight in different ways. Do not stop any of these meds. If you are on them, talk to me, talk to your provider first. That's our safety caveat there. So what are the consequences? Well, this is no secret either. We girls are the best about depression and negative self-talk. We are great at beating ourselves up when we, especially if it's been quite a while that we've been overweight or obese. You guys know sleep apnea, fatty liver disease, indigestion, reflux, difficulty getting pregnant. Both males and females are less fertile when they are obese. It is harder for them to become pregnant and get somebody pregnant. You know, joint pain, insulin resistance, gallbladder, liver disease, stroke, heart attack. If I want to sound fancy, I will use the term chronic subacute inflammation with secondary oxidative stress. That is what leads to all these things. Fat accumulation around our organs, our pancreas, our liver, our muscle, more tissue inflammation, multiple organs that are insulin resistant. You will hear more and more in the wellness space, something called mitochondrial dysfunction. Our mitochondria are the motors in our 38 trillion cells. We have a motor, and actually some cells have 3, 4, 5 motors. When those motors don't work well, our metabolism is slowed. So be aware that mitochondrial dysfunction is a consequence of being obese. And then that subsequently will lead to a 53% greater chance of being a type 2 diabetic, an 80 to 90% greater increased chance for metabolic dysfunction and associated fatty liver disease, high blood pressure in both men and women, 65 to 70%. So we know that there are some definite problems affiliated or associated with being overweight and obese. So first, some refreshers. This is the boring science part, so if you wanted to take a nap, now is a good time. Foundational physiology. Here's some players with hunger and satiety. The hunger and satiety are related, but they're two very different things. Feeling hungry, satiety, feeling full. Hunger is controlled by ghrelin, and satiety has multiple, you see them listed, multiple hormones that come into play, but tonight we're focusing on GLP-1. Look over here. I do want to take just a few moments to show you guys serotonin, norepinephrine, dopamine. I think we providers miss hugely. There is a big role in how we can leverage. These neurotransmitters are made in our intestine. About 80% of serotonin is made in our small intestine. And we have to leverage the gut-brain connection in order to help our patients sustain long-term weight loss. And then there's leptin, okay? Leptin's kind of a mixed bag. First, I will say leptin suppresses appetite. It is made in fat or adipose tissue. So you can deduce when you increase your fat tissue, your adipose tissue, you should likely have an increase in leptin, which should send your body the signal, hey, you don't need to eat so much. You've got fat all over you. So leptin can generally be a good thing, but it can become pathologic. So even as a provider, I can actually order leptin levels. And we know in patients that have excess fat, obese patients, they can create, you see it in those darker blocks, something called leptin resistance. Their leptin levels are high, so they shouldn't feel hungry, but their leptin receptor site does not work well. So they don't get that appetite suppression. So a person with leptin resistance can have high leptin and still have high hunger. That sounds very familiar for those of you guys who have heard me talk about insulin resistance. It's basically the same situation. Insulin is made in the pancreas, and insulin actually suppresses appetite. But when a person is obese and they have, I call it, too much insulin swimming around, they develop insulin resistance. Once again, the pancreas is making more and more insulin, but because that signal is not going through, because that receptor site is not working well, they are still hungry. So instead of insulin and leptin suppressing hunger in bigger folks, overweight, obese folks, they don't get that sense of fullness. And remember, the more insulin you have swimming around, insulin is a fat storage hormone. We need it to sustain life, but we do not want excess insulin floating around. So another bit of context, obesity drugs, these are not new things. We have been finding, thank goodness, and researching and looking at these things for many, many years. Orlistat, that its job is to inhibit fat absorption. Bupropion, you may know it as Wellbutrin. Phentermine, you've heard of that before. Their job was to suppress our appetite. They come with side effects, though. Sometimes those side effects are not really worth the price. In functional medicine, we will often use naltrexone in order to suppress appetite as well. And that is an entirely different conversation and talk altogether. But naltrexone is one of my favorite prescriptions. Yes, some people need a prescription to help them. Some folks just need supplements and lifestyle, but some folks need a prescription as a helping hand. So semaglutide's been around since 2005. I am embarrassed to say I was somebody who wrote exenatide Byetta. It was a daily glutide shot for my type 2 diabetics, fresh off the shelf in 2005. That tells you I've been around a while. So these are really not new. The long acting where you give yourself a shot once a week, that's the new part. So GLP-1, what does it stand for? Glucagon-like peptide agonist. What is an agonist? It's a medicine that stimulates a certain receptor in our body. Our body makes GLP-1. It's a hormone made by our intestines after we eat. So semaglutide, they altered these drugs to last longer, ballpark 2017. So it's an altered form that hangs out and allows us, it works on the GLP-1 receptors, and then we only just need to do once a week shot. Injectables are the most common form, but you heard me mention there is an oral semaglutide called Rybelsus. These meds, again, long-acting, have been around since, well, they've been initially around since 2005. Long-acting have been around since 2017, but really took off for weight loss since 2021. How does a GLP-1 agonist work? And I'll digress here a little bit. GLP, and remember I talked to you about tirzepatide, Zepbound, and Mounjaro? Tirzepatide, Zepbound, and Mounjaro, those impact the GLP-1 receptor site, and they have dual 2 action. They also act on the GIP receptor site. So this is very simplistic, but you can think of them as stronger. At any rate, GLP-1 agonist alone, what do? Number one, they slow down food leaving our tummies. We get to feel fuller longer. And food sits in the tummy longer. That's why if you have an upcoming surgery, you need to let people know that you are on this medication, because you increase your risk of aspiration when they put you under general anesthetic. That's why you need to always let people know all the meds that you are on. Secondly, these medicines act on our brain. We talked about ghrelin and leptin. They decrease hunger and cravings. And thirdly, how it works for insulin resistance, prediabetes, and diabetes. After food intake, these medications help lower blood sugar levels because they get the blood sugar into the cell. We eat food, that is fuel, sugar, carbs, and we store that fuel into our body's cells. And semaglutide and its cohorts help do that more quickly and efficiently, especially in those who have that function that's impaired, pre-diabetics, diabetics, insulin resistance. So results. It depends. You knew I was going to give you a weenie answer. It depends on the person. What else are they doing? How much weight can be lost in a healthy way? So if you don't address underlying causes, you may still lose a little bit of weight, but I'm not a betting person, but I'll bet you're going to gain it back. If someone is practicing what we preach and they're embracing into some of the tips I'm going to touch upon, they can lose up to 5 to 10% of their body weight. If they're 250 pounds, that's about a 12 to 13 pound loss. If they stay on this medication for a period of time and they're fasting and feasting, they're working on movement, maintaining muscle mass, other hormones optimized, they can lose up to 50 pounds if they're a 250 pound person. That is over 20% of their body weight. These percentages are greater in the tirzepatide, Mounjaro, Zepbound, the GLP-1 and GIP agonist. So do know there is a difference in the weight loss potential. As you can guess, there's a difference in side effect potential. I use both of those families. I use Mounjaro, which is tirzepatide. I use semaglutide. I like to microdose, and we'll touch upon that briefly. And I generally don't go above microdosing. It's not necessary if you are working with folks on all the other things, all the other bullet points. Diet and exercise alone will also get us a 5 to 10% weight loss. So you can kind of compare the two. But some folks, things have progressed to a point they may need a helping hand. They may need supplemental help. They may need a prescription help, prescription assistance. They may not, but you better start with the foundational basics. You already saw on my takeaway slide, that is one of my big soapboxes that I jump on. So side effects. Who has side effects from these drugs? The majority of people that take them, especially dependent on the dose. Symptoms or side effects are usually not severe enough for a patient to discontinue treatment, especially if the provider knows what they're doing and they slowly increase a person's dose. They talk about strategies or risk reduction so the person won't have to suffer these side effects. Using microdosing mitigates these side effects. But you see, the side effects are related to the slowed activity of your gastrointestinal tract, slowed emptying, nausea, vomiting, constipation, diarrhea. I've seen all of them, one or the other. Less side effects. You do not want to use these medications also in folks who have a special type of thyroid cancer. I actually have a patient who has had thyroid cancer in her early 20s, but she did not have the type of thyroid cancer that negates me using these medications for her. Multiple endocrine neoplasia, that is the quote unquote syndrome that we do not want to use these medications with. Bottom line is you always want to let your providers know your medicine list, your supplement list, and your health history. And you want them to be vested in taking the time to figure those things out. You see me glancing because I want to keep this moving along. There's great information I want to pass along to you. So most people, unfortunately, regain the weight that they lose, shown by the statistics on this slide, 2 years, 5 years. This is frustrating. You guys need to be aware of a concept called the energy gap. What the heck is the energy gap? We already know we don't like it, right? When people lose weight, their metabolism slows down. That is a God-given protective mechanism. If we are shipwrecked and on Survivor Island and we have no food to eat except coconuts and coconut water, we are going to live longer to wait for our rescue cruise ship to come by the island if our thyroid ratchets things down and slows our metabolism. So at any rate, when people lose weight, there's food scarcity, metabolism slows, but appetite increases. Why is that? Fat tissue is an energy reservoir, and our body wants to acquire, and it requires it because it wants to be prepared in the case of war, food scarcity. It could be 2 weeks before we shoot a buffalo or catch a fish in a stream, if you think back to ancestral health, right? So our body is designed, our brain is pre-programmed for survival. So when weight loss occurs, the brain is panicked. It again thinks, whoop, starvation, stress. I'm going to increase hunger signals to keep my person safe. I need to regain that fat tissue. I need to regain my energy reservoir. And I need to regain that fat that was just lost. This is not a character flaw. This is a normal physiologic response. So you guys need to know that. And you also need to be aware that there are ways that we can increase our odds so you can reach your goals and then you can maintain that weight loss. You know most of this on this slide. Yes, diet changes are necessary. Low carb diets have been shown to have a higher statistical advantage. High protein increases overall energy expenditure. We also increase our calories simply when we eat protein because protein takes more energy to digest. Exercise because we want our muscle volume to increase. Muscle equates to insulin sensitivity and it increases our metabolism. It's also nice for mental health when we incorporate movement on a daily basis. There's also a reason, if you look down towards the bottom, there's a reason why Weight Watchers is successful and it has a long-standing business model. Yes, people regain weight, but why do they lose weight? Because there is a support network, there is accountability, there are continual check-ins. there is ongoing interaction. We are social animals, and we do well touching base with folks on our weight loss journey. Lower screen time helps. Look at what we've done to our kiddos. There's no secret our kids are on their phones, they're playing video games. That is why they are chunky, and that is why they are set up for many, many more difficulties in their teens and 20s than we were. Eating breakfast, I do have my patients when they do time restricted eating and they're on a plateau, they have more success with weight loss if when they are skipping a meal, they're skipping their evening meal and they're eating breakfast and lunch and maybe a mid-afternoon snack. You have to switch it up because once again, you do not want your body to acclimate. You do not want your body to downregulate your metabolism. Protein powders, substituting a protein shake at night, or perhaps starting out the day with a quality pharmaceutical grade protein shake helps our blood sugar stay steady throughout the day. That assists us with cravings. So do know there are many things, but what also improves, and this is part of my takeaway, Sharice's soapbox, what also improves our chances of keeping our weight off? Somebody taking the time for hormonal optimization. What is this person's nutritional status in the first place? Have we looked at their gut health? Are they pooping? Are they digesting? Do they have reflux? Yes, there are natural alternatives to semaglutide. When do I use natural alternatives? I always use them first. First. Why would I write a prescription if a person has not tried some natural alternatives? Now, I always have to meet the patient where they're at. And I may have somebody that says, Sharice, I've been taking berberine. I've been doing all the things. I've been counting macros. I've been using apps. And they come into me and they're hell-bent on getting a prescription for semaglutide. Am I going to attempt to meet the patient where they are at in their journey? You betcha I am. I am here to serve you, but I'm also here to keep you safe. And I'm also here to not lead you down the wrong path. So often I will use polyphenols if a person does not tolerate semaglutide or tirzepatide. If I am transitioning them up, I'm trying this first. If they've lost 25 pounds on semaglutide, they don't want to take it anymore. They don't need to take it anymore. They're tired of spending $150 on a prescription every month, $100 on a prescription every month. So we may use these as a tapering or transition down to help them maintain their weight loss. These polyphenols boost our own GLP-1 GIP production. Again, the name of these are called polyphenols. We do have robust clinical studies. I'm not just winging it saying, hey, I've had 3 people lose some weight when they've taken a polyphenol supplement. There are very well designed studies that show us the validity of utilizing these supplements as a holistic weight loss, weight maintenance approach. You guys have also heard of berberine. You definitely have heard of turmeric or curcumin and ginseng. Those 3 supplements also boost GLP-1 levels. But what I'm talking about tonight with polyphenols, lemon verbena, hibiscus, and green coffee bean extract. So polyphenols, that umbrella term comprises over 8,000 different molecules that fall into classes that have fancy names: phenolic acids, stilbenes, lignans, flavonoids, tannins. Some polyphenols you've already heard of before, like resveratrol from red wine and grapes, anthocyanins from berries and grapes, you may say caffeic acid from coffee, ECGC from green tea. Polyphenols are already well known for their anti-inflammatory properties because they are a great antioxidant. And antioxidants help protect us from free radicals that are generated just from our body's normal metabolic processes. Polyphenols definitely protect our body from inflammation, and over time, they can also prevent transformation of healthy cells into cancer cells by preventing damage to our cellular DNA. But talk tonight, polyphenols are more than just antioxidants. They regulate our gut hormones. That means they support GLP-1 production. They also stimulate the growth and health of our mitochondria, those motors inside our 38 trillion cells that I talked to you about that are responsible for our metabolism. Our mitochondria are our cellular powerhouses that generate energy from food. And in doing so, help us maintain our muscle mass. And here's what's really cool. Polyphenols contribute to the browning of our fat. In other words, transforming our white fat. White fat is stored fat. It stores energy. We want to transform it into beige or brown fat. Brown fat is nice, happy. We love brown fat. It burns calories by producing heat. So that essentially means more energy being converted to heat versus energy being just stored as fat, white fat on our body. We want brown fat. That is why some folks can eat more, but still weigh less. So I had to type that in and add that to my slides about the white to brown. So it's lemon verbena, hibiscus. They stimulate metabolism. You can see these things listed here. They inhibit fat absorption. Again, you can see some blood pressure lowering effects. Green coffee bean extract, it stimulates our metabolism and it also stabilizes our blood sugar. So you can see by these listings why the polyphenols are a wonderful tool for us to incorporate in potentially in our supplement stack when we're trying to achieve weight loss or weight maintenance. We're going to take questions, but I thought y'all guys may enjoy a little case study, and I'm going to breeze through it. I didn't even do a real great job on this. This is just to let you know how weight loss and weight maintenance is multifaceted. It is so much more than somebody writing you a script, collecting your $300 check once a month and giving you a shot and said, call me if you need me. So we have Mary. She's 48. She weighs 181. She wants to weigh 150. Notice I did not put her height on here because you know what? Her BMI really doesn't matter. What really matters is Mary had a lot of abdominal fat. She did not have a lot of muscle. She had more than many of my patients though, because she does work out fairly routinely. But at any rate, to get a full picture of Mary, she has Hashimoto's thyroiditis. That means Charisse better watch her thyroid because it is inflamed. That's an autoimmune condition, and I better be looking to optimize her thyroid. She has had a hysterectomy a few years back, but they left her ovaries in. We don't know how they're working because obviously without a uterus, she does not have periods. She had to have that hysterectomy for having uterine fibroids. So as a clinician, I might think, oh, way back when, 3-4 years ago when she had her hysterectomy, she may have been estrogen dominant, which definitely can pack on the pounds. Mary's lifestyle, she did exercise. She didn't lift enough weights. She did a little too much aerobic. She was a vegan. She had high food knowledge. It is very challenging for me to keep vegans nutritionally sound without them having too many carbs when we're trying to achieve weight loss. That is very challenging. Mary was already using calorie counting apps, macro counting apps. She was using some behavior modification. She's very driven. She's a CEO. And there are a couple caveats. And I hear this not just from Mary. You have to meet the patient where they're at. I'm a foodie. Do not tell me to 100% remove everything or anything, Charisse. Like I can cut down on gluten, but I'm not going to be gluten-free. I can cut down on alcohol, but I'm still going to have 2 glasses of wine every Saturday night, but I'm not going to drink on Thursday and Friday because I know that hinders my weight loss efforts. She knew she had a sweet tooth. She knew and knows she has to watch it as a very high stress job. Empty nester. So that's kind of cool. She doesn't have to worry so much about her kiddos and food prepping for them. She does have a supportive spouse, and she's one of the lucky ones. She does not have high financial stress. So she can, instead of picking up Wiener Schnitzel, she can actually go to Jason's Deli. Or what's the other one? McAllister's, right? Or order a salad at the country club for a business meeting and get extra chicken or boiled shrimp on the side so she gets her protein macros in and accounted for. She did not necessarily come to me for a full functional medicine approach. She came to me for weight loss. But of course, because you already figured out I like to talk a bunch, I had to at least make her aware of some things that I would recommend. But of course, the patient's in the driver's seat and I am in the seat behind it with my hand on their shoulder. So we have to have ongoing communication about what she thinks is the right fit for her. But I had to get my 2 cents in and talk to Mary about you need to do more strength training, optimizing muscle mass. We need to look at your sex hormones, Mary, or you're going to be throwing money out the window. I need to optimize your thyroid because we know you got Hashimoto's thyroiditis. You've had positive thyroid antibodies before. And my favorite is when they'll say, well, they told me I had Hashis in my 20s, but nobody checks my antibodies any longer. And she's 48. And I see that time and time again. That includes at the endocrinologist, not a functional medicine endocrinologist, but conventional medicine endocrinologist. And I'm not bashing conventional medicine. It has a time, it has a place. I am very firmly rooted in conventional medicine because I practiced in internal medicine since 1999. Functional medicine gives us a grander, more glorious toolbox. So Mary needs to know about all these other things that will give her a better shot of getting the weight off and keeping her weight off as well, just as important. This kind of stinks because it's a little blurry. Forgive me. I'm just touching the high points. In functional medicine, we looked at her HSCRP. She kind of has a little bit of low-grade inflammation. Her fasting blood sugar, a lot of you would think 96. That's awesome. Not in the functional medicine world. It is our job to be optimal, not, quote, normal. I actually would love her fasting blood sugar at 83, but I definitely want it less than 90. So that's a clue to me that she may have too much insulin floating around because she got too much blood sugar. Her fasting blood sugar in the morning, that's too high. Her kidney function is fine. You can see creatinine down below, and I apologize for the blurriness. I am going to look at her AST and her ALT or ALK phos. That's her liver. She looks pretty good because I want to make sure that her liver has the ability to detox. I do not like her hemoglobin A1C. As you guys know, it's a 3-month measurement average of blood sugar. She is knocking on the door of being pre-diabetic. Less than 5.7. 15 years ago, I'd say, well, you're okay. You're not diabetic yet. Now I go, 5.6. You've got too much insulin floating around. Your A1C, in a perfect world, it's 4.8 to 5.1. I try to keep my folks under 5.3. This is something that Cherise personally has to work on. Just know that you do not get winner chicken dinner at 5.6. This is a huge warning sign that she is real close to being pre-diabetic, and too much insulin floating around is going to hinder her weight loss efforts. Maybe we need to get her a continuous glucose monitor. I did not type that on this slide. That is a beautiful tool for learning what foods impact us the greatest in terms of carbs, how different things impact our blood sugar differently. I looked at testosterone on a saliva test because that gives me hints. I need to optimize that. So I optimize her ability to maintain and build muscle mass. Here again, here is her insulin level. She's in the 8s. She's between 8 and 9. Notice that still falls in the normal range with lab work in conventional medicine. And it is normal. 16 is still normal. Anything under 25 is normal. It is very worrisome for us in functional medicine. I'm supposed to be keeping patients' insulin level and my insulin level between 3 to 5 with a steady, stable blood sugar. And that will help me decrease their risk of Alzheimer's, heart disease, fatty liver disease, polycystic ovarian syndrome, and gaining weight and having a hard time getting it off. These are some other thyroid studies that I pulled from Mary's chart for you guys. First, these are things that you've got to look at these things when I talk to you about looking at a person nutritionally. Here's her ferritin, her iron level. I'm happy with that. Even though she doesn't have her periods, I want her above 100 for her iron level, her iron stores. That's what ferritin is. Ladies who still have their periods, I'm supposed to have them above 120. We menopausal folks, I need us above, and men, you need to have your ferritin stores above 100 for energy production and supporting that mitochondria. Then we need to look at the breakdown of thyroid. Checking somebody's thyroid is not just getting a TSH, because look, with Mary, I would say TSH 1.4, Mary's normal. Mary is far from normal. Look at her free T3. It's in the lower 2s. Free T3 is the true metabolically active thyroid hormone that powers, it goes into the cell. Again, we have 38 trillion of them, sits on that receptor site and helps power you remember coloring the Krebs cycle in high school biology? We need enough free T3. In functional medicine, I am supposed to have somebody's free T3 above 3.5. I'm also supposed to make sure that their reverse T3 is nice and low. And Mary here, hers is nice and low, which surprised me because reverse T3 can elevate in folks that have autoimmune disease. It elevates in folks who are not getting enough sleep, folks who are stressed. Reverse T3, what the heck is it anyway? It goes, if you have too much reverse T3, it goes and hogs the receptor site for free T3. So you negate your great gasoline free T3 from working in the cell. So I just don't want to bore you with thyroid, but I want to let you know you can't just go get a shot and expect to lose weight and keep it off. This is multifaceted. Next page, pregnenolone. That's our sex hormone that's so important for memory. Mary's is great, but look at Mary's iodine. That's interesting because Mary does not live in the goiter belt. Mary lives here in Texas. Usually you see more folks with lower iodine in Michigan, up near there, Ohio. But I do see it as more and more folks use Himalayan salt. They're sodium conscious. So they don't necessarily get iodine supplementation in their salt shaker. So Mary's thyroid does not have a chance of working optimally when her iodine is kind of lame at best. It's not even normal. It's not even 40. And then we have to look at cortisol and sex hormones. I do that by saliva. And I threw a couple of different pictures up here for you to look at. I take these numbers, and again, I apologize for the blurriness. And I make calculations to decide individualized dosing. Because remember, Mary no longer, her ovaries are intact. That's why she looks like she has pretty much estrogen. Estrogen is estradiol. What do you do when you've had a hysterectomy? Your provider writes you a script for an estrogen patch. Mary does not need an estrogen patch. Mary will gain weight if I introduce more estrogen into her system. Her ovaries are working. Mary's progesterone is in the tank. Even though she has a uterus, she will benefit for progesterone taken orally, will assist her with quality sleep. It also assists her with mood, and it balances this robust estrogen level that she has. Mary's testosterone is lukewarm, barely normal. Would I introduce it first? Heck no. I would introduce progesterone first, and then maybe tweak and supplement her DHEA. You can see Mary's had a significant amount of corporate stress. Family-wise, she does great. But look at her cortisol pattern, her fight or flight hormone. It stinks in the morning. That's a sign of prolonged stressors. And it's high at night because she's busy worried about her to-do list the next day. So her adrenal glands, cortisol and DHEA, look how low that DHEA is. Somebody needs to address them because if not, again, why don't I just take Mary's money for her semaglutide shot? And no, you can't sleep at night because you know you are not setting her up for success when you do not look at all these tools. That, believe it or not, we ran through that in 45 minutes. I hope I did not lose anybody. This is a sample of a polyphenol. See our guys right here, lemon verbena hibiscus. This green coffee bean extract is decaffeinated. So folks that are very sensitive to caffeine can definitely take this supplement. Again, you always want to talk with your providers before you introduce a supplement, before you change around prescriptions. You want someone in the healthcare field to give you guidance about supplements and prescriptions. Incidentally, remember this code, and we can go back to this later. I'll send this out in the letter with the recording. Anybody who attended or registered for the webinar, you can get 10% off of your supplements. That's a code that you can use, so I would encourage you to use it. But again, should I just tell Mary to go out and buy polyphenols? No, I better look at her foundational support, maybe a good multivitamin. Does she need magnesium? Magnesium helps folks who are insulin resistant. And we remember that Mary's insulin was mid-8s, and we want it 3 to 5. Fish oil to help us with inflammation. So you want to counsel the patient and you want to increase their chance for success. So there's also another, check out my programs and offerings here. There you have it. I encourage you to check. We have another webinar coming up Thursday, July the 30th at 6 o'clock, and it is focusing on thyroid. Thank goodness it has a few less slides than this, so I will not take up all of your Thursday evening. But again, I do encourage you to look at your foundational support. Then you add things like berberine, polyphenols, curcumin to help with inflammation. Do not spend your hard-earned money just taking pot shots on what supplements to purchase. So let me look if I have some questions, and let me know about if you have any questions. I appreciate you guys sharing your Thursday evening with me once again. So y'all take care, okay?